Good afternoon, everyone. Thank you, Fritz. Thank you, Bobby, for getting me part of this exciting group. Now, what I would do this afternoon with you is share my clinical experience with this lens. I'm lucky enough to be part of this group since the beginning, so I have like 1.5 years experience with this product. Now, as you've heard, this IOL is specifically designed for patients that have macular disease, and the way this lens works is basically giving a good quality picture up to 10 degrees away from the central macula. Now, as Professor Hartal has clearly explained it before, a standard lens gives you a good picture in the center, but a bad picture is in the periphery, and that's good for a standard patients. Now, AMD patients, they do not use most likely their central part of the macula, they're using their peripheral macula, and they're not getting that good of a picture over there. So one way to improve their vision is with these optics, and the other way to improve the vision is by magnifying the images, and that's obtained aiming at post-op refraction on the hyperopic side, and I will go into details on how we choose our post-op refraction on each patient. Now, as it was clearly explained by the other speakers, this is how a standard lens is working. It's giving you a sharp image in the center, but not as sharp in the periphery. But if you have AMD, then you're not using your central part for vision, you're using a peripheral part of your macula, and then you're using an optical system which is not optimized to give you a good image there. What happens with this lens is that you're gently magnifying the image, and you're also giving them a good quality picture up to 10 degrees of peripheral macula. And that's what's actually making the game work. So I will be sharing with you my experience with 54 eyes that underwent cataract surgery, standard phaco emulsification, and they had all sorts of macular disease, AMD, as well as retinal degenerations, macular holes, and I'll share pictures with you. So surgery is standard surgery. The surgery I'm sharing with you is the older model of the lens, which was not preloaded, but as you are seeing here, it's really standard cataract surgery. And the lens, I like to do a 2.4 millimeter incision, clear corneal incision. So going to refraction, that's our average refractive error that we aim for, was 1.5 diopters of hypermetropia, and that's how we picked up that data. Basically, all the patients that have a poor visual potential, we want to get the highest degree of magnification possible because we're trying to help them as much as we can. Now, the other thing which you really need to keep in mind is the condition of the other eye, because of course you don't want to induce too much of anisometropia, because then the patient's not going to be happy because of that. Having said that, if the patient visual potential is good, and the patient is active, we've been placing these even on 50 years old patients, then we are aiming for less hypermetropia. And the other thing which I strongly advise if you're getting into this business of placing this IOL is that you want to make it clear to the patient that then they will have to wear glasses afterwards. That seems obvious to most of us, but it is not to patients. They just feel they want to see better, you're giving them their most advanced IOL, and they feel their vision is going to be better without glasses. So make that clear to them. Here's what visual results we got. So overall, we got a 14 ETDRS letter gain, and as was previously shown, patients that had AMD and cataract surgery, they do get, as from what is recorded in the literature, a 6.5 ETDRS letter gain, and we actually had over double than that. Now, when we split our patient population into two groups, retinal dystrophies, which again includes BEST, Stargardt, and retinitis pigmentosa, then we do get less of an increase in visual acuity. We did have an 11 ETDRS letter gain as an average, while when we go into AMD patients, we're getting a better results. And that's also because we are getting more experience with AMD patients, so I'm now picking up patients in a better way. So the patients that do receive this kind of lens are actually the ones that are getting the highest benefit. So how did we start? We started with patients that had a very large macular damage. we didn't know the lens that well, so we got a little scared and we say, let's try with patients where we have nothing to lose. So this was one of my first patients, and take-home message is that you should not start with these kind of patients, because this has extensive macular damage. She got some improvement, but improvement was not life-changing. And you don't want to start with the patients like that. You want, that's for the patients and for yourself, you want to start with a patient where you would totally see a life change after you put this lens in. So here's another case. Again, visual acuity is quite poor to start with. We get some improvement, but improvement is little. Then we started to get brave, and more brave, and so we went with patients that had better vision, 210 before surgery. But what's important is not really the visual acuity. You need to look for the size of the macular scar. Small macular scar can perform very well with this lens. Large macular scars are not giving you good results. You need some sort of area of macula that is working well within those 10 degrees. So this patient went from 210 to 7 out of 10, and that really is life-changing. So these kind of patients are those that do very well. This is dry AMD, massive drusens, confluent drusens. They do have some areas of retina that work well. She went from 3 out of 10 to 10 out of 10. And so we're getting comfortable with this procedure. We are expanding our indications. We went into macular holes. These results really impressed me. This patient basically had very minimal cataract, and she went from 310 to 10 out of 10. You have the vertical OCT here, and the horizontal OCT, as you're seeing here, the damaged area is small, and that's where you will expect excellent results. And I cannot stress that enough. So here's this target patient, 1 out of 10 vision, 3 out of 10 afterwards. I can tell you this lens works, even on these patients, but you're not going to get your best results with target patients. And the other thing is that they're usually quite young, they have high expectations, so if you want to use these in these patients, make sure that doesn't happen for your first 10 cases at least. Here is your ideal first patient. This patient is actually told us how his life has changed after this procedure. He said he went back to driving, he went back to a normal life, and you could tell he went from 1 out of 10 to 7 out of 10, and that's his best seeing eye. So these kind of macular scars, small, center, those are the ones that do perform the best. This is large atrophies. They do get some benefit, but again, if you have to pick up a patient, your ideal first patient is not this one, is the previous one. So this is a patient we did the bilateral implantation, and as you've heard from the previous speakers, bilateral is good, but what I would stress is that you should start with the better seeing eye, because the patients will feel there is an improvement in his life if you're doing your first eye. So in a patient like that, you should start with the right eye. Patients will feel the benefit, and now, surprisingly enough, when you do the other one, even though the other one is providing minimal vision, they would tell you that they feel that has improved. And the reason why that is happening is that is very well explained in this animation. We do believe, even though that's an hypothesis, that you have scotoma in both eyes. Now, even if one eye is seeing poorly, but somehow this eye is seeing some images that are not seen by the other eye, so the brain might actually fill in what is given from one eye with what is given from the other eye. So we do have the experience that both eyes is good, but always start with the better seeing eye first. So in summary, we did experience good visual improvement in all patients, and as I've said many times today, smaller macular lesions do the best. So if you have to pick up a patient, your ideal first patient has a small macular scar and visual acuity of greater than 1 out of 10. Now, binocular implants do get some benefit, as we said before, and I still think there is a need for us to have it clear what's the best predictor for visual outcome, but my comment on that is that the smaller the lesion, the better the result. Thank you for your attention.